and it's my pleasure to introduce Dr. Mancia. He's going to talk about the white coat syndrome, an update.
Yes, thank you very much.
We can't hear you.
You cannot hear me?
Yeah, here, yes.
Sorry, but my microphone is okay. So.
If you can raise your voice a little bit, or...
Okay. But can you hear me?
Yes, now yes.
Okay, fine. So let me... Okay. Okay, can you see my slides?
Yeah.
It's clear.
Okay, fine. Okay, this is the first slide I have. Well, first of all, thank you for inviting me to talk about white coat hypertension. And the previous speaker already defined what white coat hypertension is as a condition in which office blood pressure is elevated, whereas out-of-office blood pressure, either ambulatory blood pressure or home blood pressure, is within what are believed to be normal values. It is a very common condition. As it was mentioned by the previous speaker, maybe 1/3, even more, in elderly patients of individuals having hypertension, office hypertension, are eventually found to be white coat hypertensive patients. And now this condition has been regarded as an innocent clinical condition for many years, and several people still believe that this is the case. But I think that this is wrong, and we should do our best to change this opinion. In the Pamela study, which was a study we started at the beginning of the 90s, and patients are followed now since many, many years, early on, we realized that something was wrong with the belief that white coat hypertension is an innocent clinical condition. Here you have data showing that if you compare individuals with white coat hypertension from the population, the yellow histogram, with true normotensive subjects and true hypertensive subjects, you can see that the lipid profile and the glucose profile is somewhere in between these two conditions, somewhat less than in sustained hypertensive subjects, but definitely greater than the lipid risk and the glucose risk you can find in truly normotensive individuals. In the Pamela study, every subject of the population had an echocardiogram, and we could look therefore in an optimal fashion to cardiac damage. And you can see that white coat hypertensive subjects in yellow had a prevalence of left ventricular hypertrophy of 12% from the population sample, which was less than what we found in true hypertension, but definitely greater than what we found in normotensive subjects. This was only 4%, so the prevalence was 3 times as large in individuals with white coat hypertension compared to normotensive subjects. Now, this has been confirmed by many subsequent studies. This is a meta-analysis showing that in individuals with white coat hypertension, left ventricular mass is greater than in normotensives, left atrial diameter is greater, the EA ratio is less good, this means diastolic dysfunction, and carotid intima media thickness is also greater. And a greater prevalence of kidney damage or brain damage has also been demonstrated compared to normotensive subjects. But the Pamela study allowed us also to collect longitudinal data, because we repeated the survey 10 years later, and this is the only population study addressing this problem so far that has planned for having different surveys over time. Now you can see that 10 years later, the number of subjects moving to sustained, to true hypertension, was much greater in white coat hypertensive subjects than in normotensive subjects. This was the case also in individuals without left ventricular hypertrophy at the beginning, who developed 10 years later left ventricular hypertrophy. And even the risk of developing new onset diabetes was significantly greater in individuals with wide coat hypertension than in individuals with normotension. And as you can see, the risk of developing these three conditions, which are accompanied by a higher cardiovascular risk, was not marginally greater, but substantially greater, 2.5 times, twice, and so forth. And then finally, over follow-up on average, median value was 16 years. You can see that the risk of cardiovascular mortality or all-cause mortality was greater in individuals with wide coat hypertension than in normotensive subjects, although less than in individuals with true hypertension. And I think that now this is the prevailing view, that is that wide coat hypertension is by no means an innocent condition. It is intermediate between true hypertension and true normotension. Now, this has been found and confirmed now by several meta-analyses. You can see one of them, and you can see that the risk of those having wide coat hypertension compared to normotension was 38% greater, and all-cause mortality, the risk was 20% greater. Now, why this is the case? Of course, you can find a reason in the adverse lipid profile and adverse glucose profile, but even if you correct for these factors, the risk remains greater. And we can think of two reasons. First of all, out-of-office blood pressure is by definition normal, while office blood pressure is by definition above normal. But in wide coat hypertensive subjects compared to normotensive subjects, out-of-office blood pressure, 24-hour or home, is a little bit less normal than in truly normal individuals. In the Pamela study, it was 4 millimeter mercury higher, 24 blood pressure, and home blood pressure was 9 millimeter mercury higher. And we know that these blood pressures are steeply related with events. So this difference may be one of the factors involved in the higher risk. Now, lately, our group in Milan found that in wide coat hypertensive subjects, both those treated and those untreated, the number of individuals with abnormal nighttime blood pressure was also quite large. And we know that nighttime blood pressure is closely related to cardiovascular risk. So these are two abnormalities which can be found more frequently in wide coat hypertension than in normotension. Does this mean that office blood pressure elevation doesn't play any role in the increased risk? Well, I'm not sure that this is the case, because we came across in a number of studies to a role independent on other factors of clinic blood pressure for patients' outcome and prognosis. Let me give you an example. In the Pamela study, there were more than one office visit, so we could assess wide coat hypertension based on its stability. Some individuals at 2 different visits had persistent wide coat hypertension. Some individuals had normotension at one visit, wide coat hypertension at another visit. Now, stable wide coat hypertension was associated with a greater risk, but stable and unstable individuals had the same 24-hour blood pressure and the difference in office blood pressure. So in this case, the probable candidate for this differentiation was a difference in office blood pressure rather than a difference in ambulatory blood pressure. Now, a practical problem for white coat hypertensive patients is that probably the risk is rather heterogeneous. Probably some patients have a mild increase in risk or even no increase in risk at all, while others have a much greater increase in risk. How can we, in clinical practice, try to differentiate? Of course, we can count on associated risk factors, presence or absence of organ damage, but we came across some findings. One of them was when white coat hypertension was stable at 2 different visits, the risk was greater. Secondly, what we found in the PAMELA study, in which all individuals of the population had both home and ambulatory blood pressure measurements, was that ambulatory and home blood pressure are discordant in 20% at least of the subjects. In some patients, home is elevated and ambulatory blood pressure is normal, while the opposite occurs in other patients. Now, you can see from this Kaplan-Meier curve that when both home and ambulatory blood pressure were normal, incidence of cardiovascular mortality was less as compared to when one out-of-office blood pressure was normal while the other one was elevated. We call the former group a complete true white coat hypertension, the latter group a partial white coat hypertension. Now, the clinical message for this is that if you want to be more precise and have a better information, we should try to identify these patients based not only on home or ambulatory blood pressure, but on both out-of-office blood pressures. So this allows us to give a number of recommendations as far as white coat hypertension is concerned. We should search extensively for metabolic risk factors and for organ damage. We should repeatedly measure office blood pressure and out-of-office blood pressure and quantify them accurately. And we should, of course, put in action measures that improve lifestyle, given the adverse lipid and glucose profile. But the big problem is whether we should start antihypertensive drug treatment in these patients. And this is a truly controversial issue. Is in a way the weak point in the evidence of white coat hypertension now. Now, as far as blood pressure is concerned, I think the most complete study is the study derived from ELSA because it was a 4-year randomized study in which there were repeated measurements of office blood pressure, and every year ambulatory blood pressure was also measured. Now you can see that compared to true hypertensive subjects in red, white coat hypertensive subjects in white, treatment effectively reduced office blood pressure and consistently reduced office blood pressure throughout the study. But the difference was the effect on 24-hour blood pressure. In truly hypertensive subjects, there was a clear-cut reduction throughout the study. No reduction at all in ambulatory blood pressure. Some other studies have shown, however, a reduction in ambulatory blood pressure. So don't take this data as representative of all conditions associated with white coat hypertension. But the big problem and the big weakness is what happens with events. Now, the only study we have is a sub-study of the CISTIO study, very few subjects, in which compared to placebo, white coat hypertensive subjects had a reduction in office, no reduction in ambulatory blood pressure. This was very similar to the data of the ELSA study, and didn't have any significant difference in the incidence of events. But please look at the number of events. 6 versus 2. I think with this low number of events, no real conclusion can be drawn. And unfortunately, this is a limit which is with us still at the present time. Now, one way of looking at the problem, according to some investigators, is to see what happens in treated hypertensive subjects. Now, the definition of wide code hypertension has been extended also to treated hypertensive subjects, that is, those in which treatment normalizes out-of-office blood pressure, but office blood pressure remains high. And you can see a meta-analysis showing that while in untreated hypertensive subjects, risk was greater, in treated hypertensive subjects is not significantly different from those in which both office and out-of-office blood pressure was normalized. What is the problem of this approach, in my opinion? Well, in this special meta-analysis, the big problem was that, as you can see, one of the studies included in the meta-analysis, the study by Benegas and co-worker, which was by far the largest study. Well, it has been retracted because of inaccuracies in the data analysis. So I don't think we can count on this meta-analysis anymore. But there is one other problem that people don't like to see mentioned, and this is in treated hypertensive patients. Studies only count on one definition, one set of measurements for defining wide code hypertensive subjects, but also MASH hypertensive subjects. And then perhaps they can have a follow-up of 10, 12 years, looking at events based on a single set of data defining MASH hypertension or wide code hypertension. In the ELSA study, since we had out-of-office blood pressure measurement every year for 4 years, we could see how reproducible this definition is. And you can see that only 5% or 6% of the study population had wide code hypertension or MASH hypertension all the times. Most of them, it was just once that they had wide code hypertension or MASH hypertension. So it is a very unreproducible classification, which is of no surprise, I believe, because in treated patients, adherence can vary and treatment changes are quite common. So the lesson for the future is that we should move to studies in which more than one measurement is obtained to define wide code hypertension, and to analyze subjects in which the condition of wide code hypertension or MASH hypertension is found to be reproducible. So because of this, you wouldn't be surprised that all recommendations made by guidelines are not based on evidence. The American guidelines, they don't even mention antihypertensive treatment in these subjects, only lifestyle modifications and close control to see when these patients may develop true hypertension, based on the data I showed you before. The European guidelines, a little bit more complicated. Again, lifestyle modification, periodical out-of-office blood pressure monitoring, and then differential considerations based on the risk. In subjects with organ damage and high cardiovascular risk, they recommend treatment. In subjects without organ damage, they do not recommend treatment. In both cases, no evidence is available. Recommendations are based on the level of risk, no more than this. And indeed, there are no studies in which the effect of organ damage on the risk has been measured, because most of the studies, except for the Pamela study and cardiac damage, most of the studies did not include organ damage in the assessment of cardiovascular risk of wide code hypertensive subjects. But I would leave you with the final consideration. As mentioned by the previous speaker, in elderly patients, wide code hypertension is even more common. And in the Harvard study on octogenarian hypertensives, 55% of the patients probably had wide code hypertension. My question to you is the following. In Harvard, the benefit of antihypertensive treatment was a major one, 30% to 40% reduction in stroke. more than 60% reduction in heart failure, more than 20% reduction in total mortality. Now, is it believable if 55% of the patients didn't share these benefits, the entire study would have shown these benefits? So I think we have to keep this doubt in mind and try to have future studies clarifying the question, which at the moment, based on this consideration, I regard as unanswered. Thank you very much for your attention.
Thank you very much, Dr. Mancia. I'd like to start with a simple question. What about missing treating masked hypertension and missing treatment of white coat hypertension? Which is more dangerous?
Well, masked hypertension is even worse, the situation, because there are absolutely no data, not even uncontrolled data from subgroup analysis. Masked hypertension, the risk is great, and in some studies it's more or less the same as white coat hypertension. In other studies it's closer to the risk of truly hypertensive individuals. But as far as treatment is concerned, there is no information, not even on blood pressure. A study ongoing, which is coordinated by Professor Parati, and we hope that the data will be available, so to fill at least in part this gap. But at the moment, even recommendations to treat patients with masked hypertension are not based on evidence.
Dr. Tariq.
Thank you, Professor Mancia. You demonstrated...
Can you speak a bit louder, please?
Okay. You demonstrated that white coat hypertension is not an innocent condition. And some classify the white coat hypertension true white coat hypertension and partial white coat hypertension. True, the office and the ambulatory blood pressure is normal with elevation of the out of office, at home and ambulatory normal, but the office is high. Partial, the ambulatory or home, one of them is elevated. So my question, you demonstrated in one of your slides that the mortality is higher in patients with higher blood pressure in one of both, whether office, home, or ambulatory blood pressure. My question...
We haven't analyzed specifically this point, because if we start subdividing groups too much, of course, the result is that we have few events and cannot really reach any meaningful conclusion. So I cannot compare home versus ambulatory.
In other words,
but certainly, if the two out-of-office blood pressure are both normal, it looks like the incidence of cardiovascular events is less.
If the office is high,
but still greater than in truly normotensive subjects.
The office is high, but the ambulatory blood pressure is normal.
Must be high,
and
of
the
course,
home
because
blood
this
pressure
is
is
the
high.
definition. Yeah.
Do you consider treatment for this patient if the office blood pressure is high?
Well, this is the definition of white coat hypertension. If office is normal, of course, you don't treat these patients. But I'm not sure that the third treatment, white coat hypertensive patients, what I try to convey to you is that evidence is not available, but we shouldn't come to the conclusion that antihypertensive treatment is not necessary, because the obvious consideration is that these patients were included in big trials in which antihypertensive treatment has been successful. Probably they were an important component of the study population.
Is there a threshold for blood pressure? Yeah, say a patient presented in the office with blood pressure 180/100, and then at home the blood pressure returns to normal. Is there a threshold to think to start drug therapy And the sympathetic nervous system plays a major role for the pathogenesis of white coat and masked hypertension. If I decided to give, can I give a small dose of beta blocker for this particular patient?
Yes, the sympathetic nervous system is activated in white coat hypertension. And Professor Grassi in Milan measured sympathetic nerve traffic during medical visit and found an increase in skin sympathetic traffic together with blood pressure and heart rate. But having said this, our opinion is that the alerting reaction is not the only factor explaining white coat hypertension. Because there are several inconsistencies in this. White coat hypertension is not accompanied by an increase in heart rate, whereas the true white coat effect is accompanied by an increase in blood pressure, but also heart rate. And also the fact that white coat hypertension is much more common in the elderly doesn't fit with the finding that the elderly are not hyperreactive to stress compared to younger people. So I think there are other factors in addition to the alerting reaction. But I wouldn't be able to tell you which are the other factors. I think we should try to understand more about the pathophysiological mechanisms of this condition.
Thank you.
Thank you, Professor Giuseppe. Thank you so much, Professor Mancia.
Thank you.